One. We are live, sir.
Oh, yes. Hello.
Yes, sir. You can start.
Yes, yes, sir. I am just communicating with the students.
Okay.
Hello, Rishabh. Now we are starting our class. Hello. अच्छा, ठीक है. Now we are starting our. Oh. Now today our class is overview of urolithiasis. It is a big chapter because stone disease comprise almost a greater part of the urinary management system. So now I am giving a details regarding pathogenesis and the evaluation and management, medical and both surgical point of view. নেক্সট এটা কি এমনি করেই আসবে নাকি? এটা urolithiasis, the term is for urine and stone. Lithiasis means stone, so it is come from Greek word, and it is a urinary calculi of the urinary tract, both the upper and the lower tract. So, from the history of civilization, there is also the history of stone was there, because in the battlefield, sometimes the soldier are suffered from stone disease because of their in the scarcity of fluid intake, and also because of geographical distribution. And with the westernization of the our society, the stone disease are gradually increasing because of food habit, lifestyle, and also allowing the intake of water. So if we see the epidemiology, the lifetime prevalence is 1 to 15%. It varies from male and female. Sometimes in male it is 2 or 3 times more than in case of female, but there is some variation of the age because of female after menopause there is a second peak sometimes. So it depends on the age, gender, race, and geographical distribution. Geographical distribution has a major role in pathogenesis of the stone disease. There is ethnicity, the whites are more prone to develop the stone disease than the African Americans and the Asian population. The age is most common in the fourth to sixth decade, but it is uncommon before 20 years. But nowadays, we are also getting stones in the pediatric age group. So that's why the pediatric urolithiasis that is been tackled by the pediatric urologist. And even in our institute, we are getting the stones at the age of 1 and 2 years. So we have to tackle these stones because, and in most of the cases, the stone disease is due to metabolic disorders. There are, and they are treated with PCNL and sometimes ESWL, extracorporeal shock wave lithotripsy. I will coming later regarding during the management. So geography has a high impact on stone disease because hot, dry climate has a more prevalence of stone. So if we see our stone distribution, there is more stone in the northern part of India, and also in our state it is more common in Siliguri, Darjeeling in the north than in the south. And the sunlight has an important risk factor because it causes the dehydration and less fluid intake. And both are the mode of creation of the stone disease in the urinary tract. And also the in sunlight there is a vitamin D intoxication. And vitamin D in high dose it can also cause stone disease in particularly in the pediatric age group. The occupation is also relation to the stone disease, particularly the persons who are occupied in the heat exposure, like if is a work in the hot atmosphere, so they are suffering of perspiration, everything. So there is more chance of stone in that occupation. So they have to take much water. And BMI is a independent factor because in BMI there is a relation with the stone disease because in obesity, in obese person, the stone disease is much more than non-obese person. And there is some theory there is hyperinsulinemia because insulin become insensitive to the receptor. That's why the urine there is less ammonification, and so there is less urinary pH. So urine become acid, and the acid urine more predisposed to stone disease. Now, if you go to the pathogenesis of the stone disease, first there are some ions, the calcium, oxalate, phosphate, that are present after the glomerular filtration. The pathogenesis starts after the glomerular filtration, and there is super saturation of the ions. These ions are even in the because to make the stone, there must be super saturation. The super saturation is the primary criteria. If supersaturation occurs, then there are some factors come into play. There are some promoters and there are some inhibitors of the stone disease. So the first, there is precipitation of the ions and this cause the nucleation. And nucleus is the earliest crystal structure that will not dissolve. If the other factors which I have told earlier, there are certain which I will come later. There are some promoters and there are some inhibitors, and those aggregate and lead to stone formation. There are some promoters and the inhibitors. The inhibitor of stone formation among is important is magnesium citrate, pyrophosphate, nephrocalcinin, the TAM phosphoprotein. This is the abundant protein present in the urine. And there is also some other uropontine like bicunin. There are other substance which inhibit the stone formation. And I have already told the super saturated urine. This is the primary requisite to form the urine and also the pH of the urine. The normal pH is 5.8 to 6.2. So, if it is more than 7 and less than 5, that promotes to urine urinary calculi formation. There are different theories. The unified theory of plaque and plug. The Randall's plaque. This is the in the renal papilla. There is renal pyramid, and we have the renal papilla. There is formation of the subepithelial plaques, which is composed of calcium apatite. It acts as an anchoring anchor to the renal papilla. Renal papilla of the it may be the loop of Henle in the distal convoluted tubule or in the thin loop of ascending loop of Henle, and on which the crystals like calcium oxalate, calcium phosphate, they growth over the plaque and leading to stone formation. In case of Randall plaque, there is 74% stone formers in case of oxalate stone. But in case of uric acid stone, the similarity it has come to 96%. This picture is on the right hand side. You can see there is formation. This is the renal papilla. If we, this is the endoscopic view of the renal papilla. If you see through the flexivorous or rigid uteroscope, we can see the papilla is like this papilla. And here there is spot, there is the formation of Randall plaque, and over which the stone, there is aggregation of the calcium oxalate stone, and this ultimately lead to stone formation. So what's the points to remember? The upper urinary tract is composed of the urinary pelvis and the calyces and the PUJ above. It constitutes more stone in case of men. The ratio is 2 to 3 is to 1. The prevalence of stone disease, there is various geographical distribution, and in our state also it is most common in the northern side, and it correlates with the BMI I have already told, and the basic is the supersaturation of the ions. So we have to the natural inhibitor that is present in the urine, nephrocalcinin, uropontine, tamosul protein, and urinary calcium and oxalate. They are the more the ions which supersaturate and leading to formation of the calcium oxalate stone. The calcium containing stone is much more than the other types of stone which are coming later. And the plaque formation is most common in calcium apatite, which act as a anchor to the calcium oxalate crystal growth. And non-crystalline component, there is in a stone, some become radio opaque, some become radiolucent. That depends on the crystalline and non-crystalline component, which is composed of mucoproteins, proteins, carbohydrates, and some urinary inhibitors. The most common content in the calculi of some components, most common is I have told it is calcium. It is near 75%. The calcium content is the more important is the calcium oxalate. It is 60%. Then hydroxyapatite, it is 20%. Brucite stone, it is 2%. And the next coming to uric acid, struvite. Struvite is the infective stone. It is most important. It should be recapitulated in a broader sense because it is leading to chronic renal failure because patient may be asymptomatic also. So cystine is another type of metabolic disorder stone. Struvite stones. It is the stone is composed of magnesium, ammonium phosphate, hexahydrate. It is more common in women. The urinary pH is alkaline above 6.5 to 7. So it is caused by urea splitting organism like Klebsiella, Staphylococcus proteus. The infection is the predominant feature that lead to stone formation, and it can involve all of the calyces of the kidney, all of the calyces. That means when calyces are involved totally, that is Staghorn calculus. It may be partial, it may be total complete, which will come later. So this is the urea splitting organism which I've already told. Now there is composition of some stone, calcium oxalate, calcium phosphate, brucite, uric acid, and these are after stone surgery. After getting the stones, we have some stone analysis that can predict some the composition of the stone. The calcium oxalate, it is more common in the calcium oxalate, which I have told. Then come to uric acid and struvite stone. As the stones are imaged by state X-ray QB or CT or other investigations, so some stones are radio opaque. and some stones are radiolucent. 80% stones are radio opaque because of content of the calcium or calcium oxalate, calcium phosphate, or brucite. And by some stone, uric acid stone and cystine stone, it is less radio opaque. And the city appearance is that we it can told give the some information there is Hounsfield HU. That means we know the attenuation value of the stone Hounsfield unit because it has a practical implication. How will you manage the stone? The Hounsfield unit is the important factor. Generally, 900 to 1000 Hounsfield unit we it can be broken by ESWL, extracorporeal shockwave lithotripsy. But much more than the fragmentation is less. So we can the Hounsfield unit has an impact on the management of the stone disease. And there is some stones or some factor is there. As I have told, stroboid stone that is more common in case of renal infection, particularly by urea splitting organism. Similarly, cystine, there is renal tubular defect which can predispose to the cystine. And sometimes there is some metabolic disorders. In calcium containing stone, there is hyperparathyroidism, hyperthyroidism, and some idiopathic calcium hypercalciuria, and sometimes there is hyperoxaluria. So these are the metabolic factors which can be investigated for that for 24 hours urine or blood investigation that can be so we can there are one term there is stone recurrent former. So in that case the metabolic patient needs metabolic treatment in long run. So how the stone this is giving a nutshell of the pathogenesis of the stone disease. Now how the patient now we have I have to correlate with the clinically how the patient present. So the one present is a colic. The renal and it may be renal, it depends upon the stone position. It may be renal, it may be urinary colic, and and the you have to history the regarding the pain is very important. It is commonly the renal stones present with flank pain, and it may be the pain is different types in case of different location of the stem. In mid ureter, the pain is lateral flank and abdomen. Lower ureter, the pain is in the suprapubic region, urgency, and the patient at the same time present with frequency, increased frequency and urgency. If the stone is impacted in the lower ureter, sometimes the patient feels pain in the groin and the testes, or in case of female present with labia pain referred to the labia majora. That means stones impacted in the lower ureter. Bladder, the patient may present with hematuria, the patient may present urgency, dysuria, and sometimes the patient may present with acute urinary retention. And sometimes the stone, after passing from the kidney to the ureter through into the bladder, the patient may impacted in the urethra. The patient sometimes felt that it is stone, there is boggy appearance in the penile urethra. So patient may present with acute urinary retention. This is the different presentation of different location of the stone. The other patient is patient sometimes present with recurrent UTI. If the patient is present with recurrent UTI, so you should be kept in mind the stone diseases because in our geographical distribution the stone is much more common. The patient sometimes present with renal failure. Sometimes because of stroboid stone, patient may not present initially with pain. So the patient may present with either acute renal failure or the chronic renal failure. Sometimes the patient presents with creatine much more 3, 4 like that. Patient has no symptoms before that. And sometimes the patient may come with malignancy, particularly in the bladder stone. If it is a prolonged time, so there is chronic irritation to the bladder mucosa, and it leads to carcinoma of the urinary bladder. That histopathologically, normally the bladder and the upper tract, the normally it is a transitional cell carcinoma (TCC). But in case of chronic irritation like stone and the some bilharziasis, it can lead to the squamous cell carcinoma. So this is the histopathological variant because of chronic irritation. Now, what are the complications of urolithiasis? One, it is a recurrent UTI. If the stone is present in the upper urinary tract, that may be in the PUJ or in the ureter, it may completely block the excretory system, leading to hydronephrosis. The kidney becomes swelled with stagnant of urine, and the hydronephrosis, it is not infected. When it become infected, the next pathology come to pyonephrosis. So hydronephrosis is the dilatation of the PCS system, but no infection. When the infection supervenes, that is pyonephrosis. The patient, if there is patient present with stone disease for a pretty long time, the patient may present with hypertension, and other presentation are malignancy and acute and chronic renal failure. It has been already told earlier. Now, evaluation of the how will now the often the exam the question come how will you manage the management also include the evaluation of the patient. How will you evaluate the patient? So patient you have to start with history. The history is very important because we can from the history you can look at the site of the stone. It may be renal, it may be ureter, it may be in the lower ureter, it may be bladder. History should be taken very carefully regarding pain, referred pain associated with urgency, frequency, associated with hematuria. So physical examination, you should examine the abdomen. Particular point, some points to be noted that you should know the renal angle, the renal angle tenderness. That is common in case of stone in the upper urinary tract, and you should also know the tenderness in the suprapubic region, and also you examine the penile urethra. Sometimes stone impacted in the urethra, and you have to do some laboratory studies like urinalysis, urine culture sensitivity, because to rule out any infection. It has also impact on the management of the stone disease. Renal function test, you should do also the urea creatinine and some factors like calcium, phosphate, uric acid as a component of metabolic workup. There is some appearance in microscopical appearance, the typical related to the some stone. The commonest and hardest stone is the calcium oxalate monohydrate and calcium oxalate dihydrate. Both are also very hard, and the calcium oxalate monohydrate it is hourglass shape, and calcium oxalate dihydrate is envelope shaped. Brucite is the typical picture of needle shaped, and cystine is the hexagonal. Steroid stone is a rectangular, and uric acid is the amorphous type. Calcium phosphate and the uric acid is the small amorphous type. There are some picture. This is amorphous. This is the hourglass variety, which I've told the calcium oxalate monohydrate, and this is the brucite stone. This is needle shaped. This is brucite stone, and this is the envelope shaped calcium oxalate dihydrate. So microscopically, you can seeing the picture. You can also judge the what the type the stone is. So after laboratory evaluation, you have to do some imaging studies. What are the imaging studies? It can be done by a straight X-ray QB, now digital X-ray and ultrasonography. X-ray will give only the picture of the stone if it is radio opaque, but radiolucent does not give any picture. So USG have the value because at the same time you can diagnose the what is the hydronephrosis or not. You can suspected pyonephrosis because of clinical symptoms, along with some debris will be there in the collected urine in the renal system. And there are others, intravenous urograph, CT and spiral CT. Nowadays, CT has become a gold standard for the evaluation of the stone disease because if the any patient present with acute pain in the emergency, it should be done by the CT scan. It will give the any stones can be picked up by the CT scan. At the same time, you can also get the hospital unit, which I have told earlier, hospital unit, HU, and you can plan accordingly. You can plan the management. There is some picture of state X-ray QB. The first picture is showing there is radio back. When sometimes in the exam you are asked to read the X-ray. This is a state X-ray of the abdomen showing on the lower portion of the ribs and the pelvis, and there is a radio opaque. Don't show that it is a stone. It is a radio opaque shadow. Who could not tell that it is a stone now till seeing this picture because it may be another any radio opaque shadow. It may be calcified lymph node. It may be fecalith. It may be anything. The patient has any radio opaque ornaments like that. So here is the radio opaque shadow. In the similar, the it is as it is in the renal area. You can the renal area, so you can show radio opaque shadow in the renal area, left renal region. And same the another state X-ray QV, there is picture of there is a this suppose this picture is the transverse oriented and this is vertical oriented. So from practical point of view, and you can also see the level of the radio opaque shadow. It is L5, so L4 at the so when you are in the exam, you can tell this is a straight X-ray KV region of the lower thorax and the pelvis, showing a radio opaque shadow in the L4 region over the transverse process. So the ureter it is along the alignment of the ureter and it is longitudinal. So you may so there is a radio opaque shadow. Probably you will not use the radio opaque shadow. If the examiner asks then what it can be, then you can tell that maybe in the ureteric calculi. Sometimes this picture also follows the transverse process of the vertebra, so that also looks like a opacified shadow. It should be kept in mind. This is another picture. This is showing it is not a eye view. Sometimes you show the picture of eye view, intravenous urogram. This like and it involve the pelvis and also the upper calyx, middle calyx, and the lower calyx. So it is a staghorn calculus. It has involved from the pelvis. It is the branching to the upper calyx, to the middle calyx, and the lower calyx. So so the possibility is in the struvoid calculus. This is a picture of the urinary bladder and they're showing a stone. So the presentation is like that. There is a large stone. So from this you can, the patient has achieved this type of large size stone. So patient have so many complications, dysuria, urgency, everything. Just hold, the principal is calling me. Hello. Hi, good morning, sir. হ্যাঁ স্যার আমি একটু পরে কথা বলছি আমি ওই ক্লাস নিচ্ছি ওয়েবের ওই ক্লাস ওই 7th 8th সেমিস্টার এটা করার পর আপনাকে আমি ফোনে কথা বলছি আচ্ছা আচ্ছা, ঠিক আছে ঠিক আছে ঠিক আছে। Now, yes, to resume again, this is the bladder calculus. It is a large bladder calculus, and it is almost occupied the whole of the urinary bladder. So, in this case, you can this type of patient has reached so much size. The patient may have some lower tract dysfunction, may have neurogenic bladder, or may have any neuro paralysis of the both lower limbs. So, this stone size has been achieved for a uh, large size has been achieved due to this, because patient has no sensation of feeling that bladder is filled due to urine. And here the picture is not clear so much. The patient has presented with there is gas side. The picture is not clear, so you have to already ask for the um, any bladder should be and the bowel should be cleared before any do any state X-ray QV. And there is a radiopaque shadow is here. So this is the symphysis pubis. So this is the bladder lower end, and here is the prostatic urethra. So here there is stone impacted in the prostatic urethra. Sometimes you are seeing that there is no stone in the kidney, in the ureter, so no nothing. So but you should be carefully look for that, because you can miss, and so the patient may suffer further because there is stone impacted in the posterior urethra. So urethral calculi. USG is the another modality of investigation. USG is it is some some stone by acoustic shadow. That is very important. Any stone should be seen by the USG. There must be acoustic shadow. Sometimes the perinephric fat and the some debris can be shown by the sonologist or radiologist as a stone, but there must be a acoustic shadow, because here when the ultrasonographic rays go there, there is this part of the stone impede this the and give a black shadow. And here there is the picture is shows the kidney is dilated because of impacted stone, and this give the hydronephrosis. So you are seeing by USG, you cannot see by seeing the state X-ray QV there is any hydronephrosis. This picture gives stone simultaneously. You can give the renal status, the whether there is hydronephrosis. It shows there is hydronephrosis. Here is a picture that showing multiple calcium stone. Here they give the picture of Staghorn calculus, the multiple stones in the different calyces. And here the stone impacted in the distal ureter, because there is a bladder, urinary bladder, and so stone impacted there. There is the acoustic shadow is there. So these give impression there is a stone impacted in the lower part of the ureter. So USG can show the all picture of the ureter. Sometimes it is difficult to see the lower part of the ureter because of the gas in the bowel, either in the cecum, ascending colon, or in the descending colon. Lower part of the ureter could not be sometimes seen clearly, not be visible, so that can be missed. Here, there is another in the bladder. There is urinary bladder, and the stone is located in the dependent. Then the under gravity, it is located in the dependent part. So there is a large vesicle calculus. This is the IVU picture. The IVU give at the what is important is that the IVU is give the at the same time give the functional status of the kidney. Both USG state X-ray does not give the functional status of the kidney. Why the kidney is functioning or not. So it is important that there is a left renal calculi, and there is but the right kidney is functioning. Left kidney there is some faint radiopaque dye is there because it is impacted in the pelvis. So there is a faint shadow. So the kidney is, you cannot say it is non-functioning. There is a faint shadow. That means 50% of the function is present. It gives. There is another important investigation to do the functional status of the kidney. But IVU give the picture. So when it is not seen in the initial 2 to 3 minutes picture, you should ask the radio technician to take the delayed picture. You can take the picture after 2 hours, after 4 hours. So it should be kept in mind, and you should guide your radiologist what you want. Similarly, I view there are I see it give the depict the renal pelvis and the upper calyx, middle calyx, and the lower calyx. And at the other picture, there is a stone in the ureter. The same picture that was seen in the straight X-ray KV. It is here in the L4 vertebra, by the side of the L4 vertebra. The CT has the definitive value because it is rapidly performed. It can detect any stone in the any place. There is sensitivity is 100% sensitivity, any size, any type. Sometimes this small stones in the if it is not crystalline, so it can be missed by static QAV. The USG is the dependent upon the doctor who is doing that. So it is personally how competent he or she is. So the CT it can detect all stones of any size, and at the same time it can detect any other pathology if there is in the renal system or not. So there is some importance of the CT. This is a different picture of the spiral CT showing different carry stones in the pelvis, in the lower calyx. In the there is some small stones can be also seen. It is 3 to 4 millimeter. So medical management, we come to medical management. It is indicated in the small uncomputed stones. So we are the stone size of 5 to 6 millimeter. It can be passed spontaneously. So we give the alpha blockers. Initially, there is a calcium channel blocker was used, but there is a side effect because of hypotension or like that. So nowadays, alpha blocker is recommended for for a short time. Some the ureteric smooth muscle relaxation, and the fluid at the same time patient have to advise the fluid at least 1 glass per hour, and if she should at 4 to 5, don't overeat it. The patient you should, because if the patient take much more water in a small time, there is the patient is become restless, there is vomiting and everything. So 1 glass per hour during the morning hour it is sufficient. And the patient along with the you have to give any antibiotic, you give to any NSAID, some painkiller after seeing the renal functional status. There is also there is some there are many papers regarding expulsion the rate of the stones with calcium channel blocker and steroids. I've already told. Now it is alpha blockers and not with the deflazacort. Now it's been come. Deflazacort is given in the 5 to 30 milligram and variety doses. There is some formulation and it expedites the stone expulsion. It has been proved in the literature, but it is given for a short times. But you have to judge the size of the stone because not in each and every stone, because lower part of the ureter it is the most smallest diameter, it is 3 to 4 mm. So if the stone size is much more, 5 to 6 mm, there is expectant treatment, particularly in case of women and the young children, because the ureter is dilatable. But again, you have to judge that for if the patient presented with bilateral ureteric stone with obstruction and so many with so many picture which is not for expectant treatment. So in that case, you have to take a tackle for urgent management. You have to do any other management. So not patients are suitable for the medical management. It is no need urine flush therapy. There is initially used for flush therapy. It is called there is extravasation. There is rupture of the calyces and there is formation of the urinoma. The rupture. Too many pressure given to the ureter by through the ureteric catheter. There is rupture of the all the calyces and the formation of the urinoma. So it is not a done today. Now come to the surgical management. The surgical management. So renal calculi. The renal calculi you have done the imaging. You have got stone. There is some size. There are so many modalities of treatment. There is ESWL, extracorporeal shockwave lithotripsy. There is percutaneous nephrolithotomy, and it is called PCNL. And the sandwich therapy. Sometimes the stones are so large that cannot be tackled by ESWL or PCNL. In that case, both the modality can be combined together. And another variety is the nowadays, it is very popular and is RIRS, retrograde intrarenal surgery. It is the endoscopic surgery. And PCNL is also endoscopic surgery. Sometimes, in other word, it is called keyhole surgery. And the other is laparoscopic and also the open. The open is the lowest place nowadays, but it is still to mention it is open surgery. Now, accordingly, the size is very important to dictate the management of the stone and also the availability of the all the gadgets in your hand. So, if it is less than 1 centimeter, the stone is asymptomatic, so you can observe it and you can give the medical management, particularly 5 to 6 mm. But if it is 1 centimeter, but it is symptomatic, then it should be treated. If the treated by ESWL or uterorenoscopy, RIRS. Uterorenoscopy that means flexible RIRS, retrograde internal surgery. So 1 to 2 centimeter, you can do the both the option you have ESWL and percutaneous nephrotomy. More than 2 centimeter, the ESWL has the stone clearance rate is much less than PCNL. It has been proved. So more than 2 centimeter stone, there is PCNL is the primary treatment, and particularly also important is the calicial. Which calyx we have to interpret the position of the stone. If it is in the lower calyx, then the 2 centimeter cut-off margin will not apply. It is 1 to 2 centimeter. So in lower calcium stone, the management ESWL again the clearance is much less in case of lower calcium stone. If it is stored in the lower calyx, in that case you have to do either if it is fill in the criteria less than 1 centimeter or sometimes 2 centimeter, then you can do a RIRS or PCNL. What option you have? So lower calcium treatment ESWL is not fit for ESWL because clearance is much less. At the end of the treatment, you have to see the stone clearance from the kidney. That is the ultimate aim. So ESWL we are doing as the we are now doing two modalities of treatment ESWL and PCNL. And do both the systems are available in our institute. We are doing the ESWL and also PCNL and or the RIRS. All the options have been at NRS Medical College. So ESWL indication less than 2 centimeter, favorable pelvic calcium anatomy, that is very important because you can fragment the stone in the kidney, but it should be cleared. So there is some point is there, and the patient preference. Sometimes the patient we don't go to the any invasive procedure because it is a non-invasive procedure. It can be done done outside OT in a separate room, which have the both ESWL facilities. So treatment state here is the imaging the ultrasonography machine. Uh, the ultrasonography machine, the ESWL, which is the some integrated devices there. One is ultrasonography and what is fluoroscopy. Because you have to during ESWL, the shock wave is generated. There are according to the generation of the shock wave, there is electrohydraulic, there is piezoelectric, and there is electromagnetic. Three types of three types of electric generator is there. So what we have, the electromagnetic coil is here. The machine what we have, it is electromagnetic. So electrohydraulic, electromagnetic, and piezoelectric. This is the generation of the shock wave generation. So ESW is not suitable for patient. So stone more than 2 centimeter, and along with some contraindication is there because if there is coagulopathies, if the anatomy is unfavorable, what anatomy? You have to look the pelvic calyceal angle. It should not be acute. It should be more than 90 degree. That is suitable for drainage. And also the depth. In the case of obese patient, it should not be more than 10 centimeter. From the skin to surface depth should not be more than 10 centimeter. And the stone should be. I have told already hospital unit. It should not be more than 1,000. And the stone should be not be in the calyceal diverticulum. Diverticular stone treatment is PCNL. It is not treatment for ESWL. So there is some contraindication for doing the ESWL. I've already told electromagnetic, electrohydraulic, and piezoelectric generator. According to there are different machines. What we have, the electromagnetic generator. There are some picture. Here there is electromagnetic coil is there. From here the shock wave is generated and is there is acoustic lens. What is the waves that are generated in the electromagnetic coil that is focused by means of acoustic lens in the here this is the patient target organ, here is the stone, so you have to focus. So and this is the setup of an ESWL room. What we have, we have the this is the ultrasonography machine, this is the CM integrated machine, and this is the table, and by means of this we can locate the stone. There is CM, we can locate the stone and we can give the shock wave through this device. There is the device, composite device is there. So location is the important, device and the patient position. The table is can be changed, the position can be up and down, it can be lateral, medial, rotation, everything is by the remote control. So this is the ESWL room what we have, and this is the mechanism of mechanism of stone fragmentation. This is the site of our interest. This is the stone location. There are different method. There are different mechanism how a stone break. I think it can be tell by spalling. Sometimes spalling, shear stress, cavitation, the bubble formation. Everything is the mechanism. It is not under your curriculum. So the after fragmentation, after fragmentation, the stones we naturally keep to 3 to 4 mm. 3 to 4 mm size is the that can be tackled by if you take fluid intake adequate, then it can be spontaneously passed. We ask the patient to use the strainer during 5 to 7 days, and it is the daycare service. The patient is getting the total shock wave is 30 to 3,000 waves we are given according to stone size, stone hardness, and the patient is discharged on the same day with given some advice. The PCNL, one other other is the non-invasive procedure is ESWL, and now it is the invasive procedure. It is routinely done in our center. So it is one. It is minimally invasive. The stone clearance is much sometimes comparable with ESWL in certain situation, but it is stone clearance is more or less 98 to 100%, less morbidity. But the procedure should be done adequately. In expert hand, it is less morbid, but sometimes there is the PCNL is also complication one. It may happen anytime. The size more than 2 centimeter. Staghorn calculus, when the stone burden is much more, that can be tackled by PCNL. It may be in the same setting, it may need multiple puncture or everything. And if there is failed ESWL, you have chosen the patient for ESWL, but it has failed. In that case, you can take the patient for PCNL. I've already told there is a location of the stone by fluoroscopy or USG guidance. Fluoroscopy has the radiation hazard, but nowadays USG guidance, we have both these modalities, both the fluoroscopy and the USG guided. And there are some procedures, guide wire insertion, dilatation, nephroscopy, lithotripsy, stone retrieval. It is a detailed procedure by a insert. This you have to remember. This patient can be tackled by USWL, no other one. USWL, the one option is the PCNL. There are every procedure has some complications. The more important is the hemorrhage, and sometimes the patient have done successful stone clearance, but patient come with intermittent hemorrhage, and in that case, sometimes the hemorrhage may needs angioembolization. That means we have to there is some bleeding, some bleeding from any other interrenal blood vessels. So there is arteriovenous fistula during the puncture. So there is maybe bleeding from that site, and that can be tackled with angioembolization. You have to embolize these vessels. Another important is the sepsis, adjacent organ injuries. There may be bowel injury or spleen, particularly on the left side, and on the right side, there is injury to the liver, and it may be sometimes difficult position maintaining, sometimes failed, and there is chance of perforation of the renal pelvis and the ureter. It is usually gone through the renal renal cup, not through the pelvis. Another variant is the retrograde internal surgery, that is commonly called RIRS. RIRS it is a newer one, but it is also more last 5 to 6 years. We are also doing this type of surgery here. We have the scope here. Now we are as we are this is a costly instrument. So we are here in many centers they are doing the stone size up to 3 centimeter, but in our center we have fixed it to the 2 centimeter, because this is a flexible scope. This is the flexible scope, and there are so many bunch of fibers there. So it may damage in that the fibers. If damaged, then the vision become unclear. So we have chosen in our center. We have chosen only for small stones, difficult calyces stone that can be tackled with RIRS, lower calyceal, because we can the flexible scopes can be bent like it. The stone is here. We can pick up the stone. It can be bent to up to this much degree can be bent, and the stone can be retrieved from this. So that is the beauty of this instrument. This is newer modality of treatment, and we have this modality. We have two scopes at present. We are routinely doing this type of surgery here. Another, it cannot be completed without saying the open surgery, because it is our parent surgery. Stone free rate is more or less similar. Nowadays, open surgery has come down very small, but yeah, still it has done in some type of surgery that is extremely large staghorn calculi, because patient will take a long time and a multiple sitting. In that case, you have to choose for large staghorn calculi. That is very important. Unfavorable carotid system anatomy. Patient with body habitus cannot do that the fluoroscopy procedure. Body habitus. The patient is severe kyphoscoliosis, or regarding that patient cannot become lithotomy on the table. In that case, we have to choose for open surgery. And sometimes the patient may present with stone with no function. Okay. No function. We have to done the DTP scan, diethylene tetramethyl pentacetic acid scan, before, because you have to prove it that kidney is non-functioning. In that case, that should be do a nephrectomy. It is a very untoward incident, but sometimes the patient, neglected patient present in the late stage, patient stone disease, pyonephrosis, and there is no function. The kidney become anaphytic, and there is xanthogranulomatosis pyelonephritis. One feature is xanthogranulomatosis pyelonephritis. That is kidney look like a stone huddle like, and sometimes that had to be removed by nephrectomy. The renal stones, there is pyelolithotomy. The pelvis is horizontally exposed, and the stone is tackling out, and there is repair of the pelvis. There is the extended this is called extended pyelolithotomy. It is simple pyelolithotomy, and it is extended. We have exposed the upper calyx and also the lower calyx. So extended pyelolithotomy, there are stones are taking out. Now, urinary calculus, just like renal, we have told the renal calculus. Now we are talking about the urinary calculi. Normal, if you course the ureter, there is some narrowing, the UPJ narrowing. One is narrowing UPJ, one is the just crossing of the iliac vessels, iliac vessel crossing, and another ureteric orifice. Which I have told earlier, there is a narrowest opening is here. So normally there are three constriction in the normal ureter. UP three narrowing diameter 3 millimeter, iliac vessel crossing হচ্ছে 4 mm. So normal হচ্ছে, so sometimes, so you may have questioned the how 5 to 6 millimeter stone pass out. The ureter, it is stretchable. Ureteric muscle can contract and relax. That's why, just like propulsion movement in the guard, this is also propagated the stone like 5 to 6 millimeter size. The size of the stone is most important in the management of erotic stones. Just we give a picture, the for less than 4 mm, 80%, 4 to 6 mm, 59%, and more than 6 mm, 20% chance of spontaneous passage. With the help of alpha blocker, we can give tamsulosin, we can give alpuzocin, and with the addition of diplazacort. Now, in the straight X-ray, the ureter is divided into three part. One, the proximal, up from the PUJ up to the sacral margin. In the X, when you read any X-ray, particularly keep in mind, during radiologically the ureter is divided into three parts. From the PUJ up to the upper border of the sacrum, it is the first part. It is the middle ureter, the part lying over the upper border and the lower border of the sacrum. It is the middle part, and this is the from there to the UVA junction. This is the inferior lower part, distal. So it is upper, mid ureter, and the lower ureter. So accordingly, you can see the where the stone is. Stone is in the upper part, or in the middle part, or in the lower part. So that is also for radiological classification in the upper, middle, lower. But from the this is radiological classification, and the one is other is endourological classification, that comes into the only the iliac vessel, above the iliac vessel or lower the iliac vessel. So it is two part, radiologically three part, and endourologically two part. We can accordingly we can locate the stone. So size is important. So if it is 7 millimeter, the management we can spontaneous passage when it should not be associated with any fever sepsis. But sometimes the patient present with impacted stone in the ureter and the patient present with sepsis or fever. In that case, you have to do the bypass. You have to buy or the either degescenting or you can do the nephrostomy. Is the antegrade nephrostomy. So 7 millimeter impacted stone, you have some of the management and ureteric stone more than 7 millimeter. It is treatment either by URS or either flexi or rigid or ESW. You can do also ESW if the stone is located by means of ultrasonography and the CM. You have to locate the stone. Otherwise, ESW could not be given the focusing point. This is the rigid URS and this is the flexi URS which I have told the flex RIRS. This is for RIRS. This is a different variant adult one. This is a pediatric one. In case of pediatrics, URS, this is semi-rigid. This one is semi-rigid. Now, large ureteric stones, it can be we can how the rigid URS. The rigid URS go to the urethra up to the ureteric orifice. Then we can go to the stone, and that is fragmented. That is fragmented is done by I have already told you, it can be fragmented by there are so many devices. It can be either by means of ballistic, it may be open ear, compressed ear, or means of laser. It is intracorporeal. What we have ESWL, it is extracorporeal, but it is intracorporeal because you have rigid ureteroscope. You have inside the ureter. Your scope is inside the ureter. You have giving the shock wave from outside, but your instrument is inside. So this is ballistic. It may be ultrasonographic, or it may be extra hydraulic, electrohydraulic. So type of lithotripsy, I have told pneumatic or ballistic. What we have the pneumatic one, and also we have the uh, energy generated by movement of the projectile transfer energy stone. What we have the ultrasonic. Most commonly use the pneumatic, and what is the ultrasonic? This also have we have also this one, and the function of this one is the very it takes long time to fragment the stone, but the chance of perforation everything is less in case of lithotripsy. And there is laser also. We have the laser. We have the 100 watt holmium laser. We have also laser because laser it is used for stone fragmentation and also for prostate surgery. We have the both the type of lithotripsy intercorporeal. So the complication we have already perforation stricture because here your instrument is inside, so we can perforate the ureter. And after, as if it is a prolonged time procedure, after removal of the semi-rigid ureteroscope, the patient may present with stricture. The stone may be impacted to the submucosa. You can push the stone to the submucosal level, and there is sometimes the dreadful complication is the ureteric avulsion because you have entered this ureter rigid instrument. So suitable size of the instrument is very important. There are so many size 5, 6.5, 7, 8.5 French. So the if you enter rigidly into the ureter, then we are coming out, the whole of the ureter is avulsed. Many times it does happen. Many times. It is emergency procedure. So ureteric avulsion is the most dreadful complication of the URS. We all should be kept in mind because several times it is going to happen, and I have to tackle so many cases both outside and in our institute. Uh, Uterolithotomy, this is the open procedure. The procedure cannot be end without saying the uterolithotomy. It is the parent one. There are so many approaches. It depends upon the stone size, location, everything. So this is the vesical calculus. I think the stone in the bladder, it can be tackled in a various ways. It may be primary, it may be secondary. So secondary, I've already told, it may be due to recurrent stasis, it may be due to neurogenic bladder, and there is bladder obstruction from the prostate or any other pathology. This is the bladder calculi. There are different modality of treatment, and nowadays Parkinson's hysterectomy or open surgery like vesiculithotomy or vesiculithotripsy. Cystolitholopexis is dying endoscopically. There are different modality of treatment of bladder stones. So the open surgery is the open surgery. Blood is taken out from the recurrent stone. There is another. If you are tackling the stone for the first time, there are some pathology, the metabolic syndrome, or like diabetes, hypercalciuria, hyperarousal. There is different. The patient may present uric acid stone. The patient may present with recurrent stone. So you should have to some uh, you give some advice to the patient to prevent this stone recurrence. And you have to do that. And nowadays, the metabolic workup should be done both in case of primary stone former or it in a recurrent stone former. The fluid intake is very important. You have to take such fluid so that the daily urine output should be 1.5 to 2 liter per day. It depends upon the patient profession and also the working environment. So at least should be. And the increase urine output reduce the supercharger of the urine. What I have told regarding pathogenesis, it should be tackled. The dietary management is important. The decreased dietary animal protein, sodium restriction is very important. The maximum is 2 gram per day. Weight reduction, BMI is important in the stone formation because so obesity has a role. Dietary oxalate has to take a reasonable. Vitamin C large doses may cause, vitamin D large doses may cause of stone formation. So calcium supplement should be very cautious regarding supplements of calcium because extra calcium may cause hypercalciuria and may precipitate stone formation. Calcium rich in food should be milk product and cheese should be avoided in case of hypercalciuria patient. Not strict recommendation, but not strictly, but it should be it in a balanced way. So some recommendation is the good water intake, citrus juice, patilibu rose without salt. Some food should be avoided. Spinach contain most purine content, chocolate, nut, and tea and wheat. There is some you have to do some metabolic workup in the patient and should be treatment accordingly. Renal hyperplasia should give thyroid diuretic, hyperparathyroidism. If PTH level is hard and cannot be controlled with medication, then the parathyroidectomy, hyperuricemia, patient receive gouty diathesis. Patient may give allopurinol or fevicrist. Cystinuria, hypocytria, potassium citrate, infection stroke should give the citrate or acetohydroxamine acid. So there is something the city has now become standard therapy, medical management limited role, but it should be in some cases the more treatment of in case of PCNLA, RRS, and ESWL. And nowadays also open surgery has the role, and there is open surgery that is open asked in the exam, the anatopic pyelolithotomy. If there is staghorn calculus in the it containing all of the calyces that can be tackled with anatopic nephrolithotomy by open surgery. You can take the control of the renal artery and then you can through the broadest lines you cut the kidney and remove the calyces. Each and every stone should be removed. And if there is stricture in the calyx infundibulum, then infundibuloplasty has been done in the same cases. So anatropic pyelolithotomy is the another term in case of open surgery for staghorn calculus. Metabolic evaluation is very important and to detect the high risk group, and accordingly dietary modification come into the point. So there is in stone disease there is still some controversy, some unresolved queries are there, because in some cases of particularly in steroid stones, magnesium, ammonium phosphate stone, there is stone becomes so large, still the patient does not have any complaint. So still some has a small stone, large stone, that is the complaint. And sometimes it is a why stone disease is common in one side and that is other side is not affected. There is some unresolved queries. Thank you. দেখো তো দেখি কোথায় আছে। হ্যাঁ, আমার ফোনটা এসছে কি? আমার ফোনটা দাও তো দেখি ফোন। ঠিক আছে। এই পার্থ সব হয়ে গেছে সব? কি জানি। Ureteric line of the ureter. So there sometimes pen is referred to the loin to groin because the stone is impacted and there is stretching of the ureteric mucosa and the ureteric wall. And so pain radiates along the supply of the ureter along to the loin to the groin. And sometimes there is also infection also supervene. The infection is another cause for migration referred to the pain from the ureter to the loin to the groin.